Good morning. It is still morning, hard to believe, but good morning, everybody that's joining us. I'm sure there'll be people trickling in as it gets moves on into the hour. My name is Dr. Stephen Philippi. I'm the director for the Center for Evidence to Practice at LSU Health Sciences Center. Several of y'all have worked with us in the past. We've been working with LDH for a while on workforce development issues. Particularly around evidence-based practices. Most of the work to date has been in the child and family evidence-based practice rollout that we've been doing with Medicaid and supporting those efforts and training providers and helping reach kids and families with a higher quality of care throughout Louisiana based on those practices. So this is a little bit different, in a lot of ways the same, a little bit different. So this is certainly focusing on adult crisis services, but our role is essentially the same. We are been asked to help with workforce development, training, implementation of the practices as outlined. So I also want to call your attention. We are recording the video, or recording this presentation for two reasons. One, we want to capture questions accurately. The second is we can also post the video of Q&A faster than we can translate all this into a paper form or frequently asked question form, which we will do, but because of the nature of how these applications are being requested and the due dates, we want to put this up as soon as possible for people to reference back. So with that, I'm going to go ahead and jump in and just go through a couple of things. So one is, hopefully all of you all have been on other calls that we've done with the state. So I'm not gonna spend time reviewing what the actual crisis response system is. That has been done in partnership with us. We've been on most, if not all of those calls at this point, through statewide webinars, through regional meetings that have been held, and describing what is the goal, what is the new Louisiana crisis response system that is being rolled out. The service definitions for that are posted. The Louisiana Department of Health has a very active website that maintains a lot of materials on what the system is. So I'm not going to spend time on that. Today, just to really set the expectations, is really focused on dedicated to answering questions about the training RFA. For those of y'all that have worked with us in the past, this isn't a new process. We do this when we roll out evidence-based practices in Medicaid, but it's important to know that people are ready to do whatever they're requesting to be trained in. So that's what this RFA is. It's a application to be trained. Because this is a soft launch, and I'm probably going to say that a lot, and also in relation to questions that may come up, because this is a soft launch, we're being very specific about trying to identify those folks that are most ready to proceed into this crisis system, so we can start standing it up throughout Louisiana and get it started. As a permanent feature, hopefully, that is certainly the goal. But we need to get it started, and we need to focus on who's most ready to help the state move this thing forward and get started. So that's the focus of the training application, is that readiness. So hopefully the folks on the call are people that are interested in applying to be trained. Those are the questions that I want to focus on and respond to today. If you ask questions about the overall crisis system, my response is probably going to be pretty consistent, which is directing you back to the service definitions, the LDH website, to answer most of those questions. In terms of asking questions, we've got the chat feature, Q&A chat feature. Please feel free to type your question in related to the RFA and training. Happy to take questions that way. The teams here from the center, Hashima, can also monitor if you raise your hand and you want to be unmuted and ask your question live, you are welcome to do that as well. We'll try and cover as many questions as we can in the course of the next 50 minutes or so. If you do think of questions after this session, that's fine as well. What we've done, and some of you all may have already experienced that, if you send the questions to the center about training, what we're doing is we're taking those questions in fairness to everybody and converting those over to our frequently asked questions sheet. And we are going to have that posted. So if you send us a question after this, we will take it. We'll look at it. If it's pertaining to training and this RFA, we'll answer it and we'll repost it live on the website. Sorry, not live. All right. So let me just call your attention to, obviously, the RFA is out. If you received the email about this Q&A session, you also have access to knowing where that RFA is. But if you don't, Center for Evidence to Practice if you just type that in, it'll take you to our website. All the information is on our landing page, accessing the RFA in terms of its entirety, the background, every question. And we do encourage everybody to read that first before then going into the actual application. Hashim has just dropped that into the chat. It's laevidencetopractice.com. Before we jump into questions, I'll just highlight one thing, because I'm assuming a lot of people are going to know. In terms of review, we have a wide array of reviewers, including reviewers from the center, reviewers from managed care organizations, reviewers from advocacy organizations of Louisiana. In terms of what are we looking for in terms of readiness, this is all pulled from the implementation science. But we're looking for leadership. We're looking for organizational infrastructure. What do you already have in place? Or what can you describe that you are actively planning to put in place? And does that plan make sense? What is your organizational capacity and capabilities to expand to crisis services? Or even if you are a current crisis service provider, how do you move those crisis services to match what the proposed service definitions and activities in this specific crisis response work for the state might look like? We want to know your experience with crisis service implementation. If you have it, great. If not, we certainly want to know more about how that might fit with your organization vision, mission. We do want to know about your cross systems experience. One of the key ingredients in this is it will take a great deal of local collaboration. This will require providers that can really connect with their local and regional leadership, law enforcement, emergency departments, healthcare authorities. It's going to take a lot of coordination. So we're going to be looking for that cross systems experience. And then probably the most significant, at least, again, go back to the soft launch idea, the most significant thing in this is the ability to engage in an innovation and new transformational service. There are a lot of organizations that I am certain will be ready to jump into this work at some point. But when you're talking about starting up a system, especially a statewide system, there is going to be a lot of hiccups that we're going to have to figure out with the organizations that are most ready to go forward and problem solve in real time. And some organizations have a great bandwidth for that. Some organizations, that's not their strength. They want, things more further along and more solidly structured before they jump in, and it totally makes sense. So we are looking for partners that are ready for innovation, high feedback, high discussions, actively engaged, high problem solving abilities, things of that nature. Hashima, can you go to that next slide just so we can highlight the dates? and everything. So just in case you're wondering about any of this, so just a reminder, it's all in the RFA, but the RFA is located on our website. Like I said, this is the actual complete website connect. This video for this Q&A and the fact sheet will be posted at the LA Evidence to Practice as indicated here. The deadline for the RFA submission is October 27th, which will be coming up soon. We will be doing final selection, so we'll be doing a lot of reviews with the group, final selection of the folks that are viewed most ready to take on these services by November 15th. And then we are anticipating to have the mobile crisis and the community support groups, the training ready to go and start actively training those groups starting right at the beginning of January. So all important stuff to keep in mind. The last thing that I want to go over before opening to questions is just bringing your attention to questions that we have received, and these will be on our FAQ sheet that will be posted. But so a question's already come in about what are the training requirements to become eligible to contract with MCOs to provide the new crisis services. The answer that we have already crafted and is in the FAQ that will be posted is that the Center for Evidence to Practice, in partnership with LDH and the MCOs, is planning a combination of asynchronous on your own, live online, and in-person training events. The exact hours aren't finalized yet, but we are expecting it to be at least 16 to 20 hours of pre-service training. So that should be anticipated. The training will focus only on crisis services. And so agencies, you all know that you have a breadth of other orientation and training that you do with folks, and we certainly don't want to overlap with that. But agencies will be expected to provide other orientation training for their employees, including things like basic first aid, CPR. And then after that initial training, that initial 16 to 20 hours, as part of the training, we will also be doing monthly coaching sessions with teams for the first 6 months of service delivery. So that's one question that we already have and have answered, and we'll post that. The second question, there's 3 questions that I just want to cover quickly. Second question is, we currently have a crisis intervention program at our agency. We provide crisis stabilization and intervention services to our clients. In order for us to provide crisis intervention services to our clients, are we required to apply for the crisis response system? So the answer to that, as I understand it, is all Medicaid behavioral health providers are expected to have crisis care, urgent care policy plan for their clients. Crisis care is already a specified part of certain programs like the ACT programs, PSR programs, certain CPST programs. This training, this specific training, this RFA is specific to providers that would be part of the new crisis response system and the service definitions that are clearly outlined by LDH on their website. For providers to be eligible for contracting with MCOs for these services, they must complete the training as part of the initial launch of these services. So that is that one. And then the last question that we've already received, and again, just letting everybody know, has LDH thought about including universities in the conversation as part of workforce development? The answer is yes. LDH welcomes inputs from the universities as we continue to develop the crisis system. Currently, LDH is working with us here at the center, and we are focusing on collaborating with communities, developing the training curriculum, helping identify potential workforce members, and developing and conducting continuous quality monitoring and quality improvement activities surrounding that workforce development. So with that, I really do want to hush and get to the questions, and I know there's several already in the chat, so I'm just going to go in the order that they were received. And again, if you want to ask any specific questions that you would rather ask verbally, feel free to raise your hand and Hashima can work with you to get you off of mute and ask those questions. So I see, go ahead.
There's one question in there in the chat.
I thought there was more than one.
It is, what is the, and this is probably more programmatic, but what is the per diem reimbursement?
So the per diem reimbursements are part of the RFA. If you go to the RFA page and you go to the attachments at the end, they are all listed there in the attachment, and that includes all 4 levels of the crisis care. My understanding is LDH is also going to be posting those on their website. If they haven't already, it is definitely going to be posted there as well. So go to if you open up our RFA and go to the very last page, you'll see the details of what those agreed rates are. The one thing I do understand in just conversations with the managed care organizations about this is that is something that you need to agree to and think through up front. Those are the rates as we understand it that are set, and that's what you can anticipate as you try and formulate the business planned around that. Some of these, just some of the other messages, I think some are coming in direct to me, so I will put those out there. So what is meant by question 4B under leadership? An example of crisis implementation we've already done. So give me 1 second. Let's need to go to 4B real quick.
I'll pull it up.
It'll take me a second. So 4B reads as provide an example of implementation or planning as well as an outcome associated with each of the following. And 4B is our agency leadership perceives the Louisiana crisis response system as achievable. In other words, it can be implemented as a significant advancement in the delivery of crisis service in Louisiana. So, so we want, this is looking at, we know some of y'all's agencies are very big and this takes buy-in. Smaller agencies, certainly the leadership is very close to the frontline services. Bigger agencies, sometimes it's a little bit more distant. We want to know that the agency's leadership understands what this endeavor is going to take, because it's going to take an entire agency system, including that commitment to be part of this particularly soft launch and the complications that is to go first and be part of this initial implementation phase. So we do want to know what your leadership thinks about being part of that, that you actually do see it as doable in terms of your agency. And if you have an example of how you have done that kind of work before at any crisis care, we'd certainly like to know exactly what that example is. Another question that's in at least my chat, I need the email address again to send the 3 letters of recommendation. I've already completed the application. It's a great question. We do know that there's a little bit of a nuance about the application that I do want to highlight for everybody. So everything in the application you can fill out on that forms. You can drop your answers in that. The one thing that we did not do is attach a Dropbox to the actual form. So you do have to email. So it's a 2-step process. Fill out the form, and then when you get your letters of support from your local area and region, we do want to see those, and you email them directly. Hashima, correct me if I'm wrong on this, but you do email them directly to our evidence to practice email address. And Hashima can drop that email address into the chat as well. So it's a great question. It is on the RFA where that email address is, but we'll put it out there in the chat and also make sure that's included in the FAQ again. Another question.
Go
Another
on.
question. Go ahead, Hashim. Sorry.
No, you can go. You can go.
I'm just going down the list. Some of these were direct messages to me, so I just want to make sure that
Yeah.
everybody's getting the same thing. So the next one that I have are, what are the firewall boundaries expected between voluntary and involuntary individuals during treatment? Can this be determined through policy and protocol? Great questions, and obviously also an example of how people are paying attention to the nuances of this crisis system versus what currently exists in Louisiana. So if you do things like crisis care beds and you actually have involuntary placement crisis care beds, or you belong to a, for example, a hospital system that also takes involuntary folks through the emergency department, we want to know, how are you going to keep that separate? This is a culture shift for Louisiana, and we've presented that over and over again with LDH in those statewide and regional meetings. This is purposely going to be very focused on voluntary, person-centered, resolution-focused, recovery-focused care. It's very different from what we've had in Louisiana. And it doesn't mean one's better or worse. We're not taking apart anything that currently exists. Involuntary commitments have been in part of Louisiana, and they're going to continue to be. But if you happen to be one of those organizations that has that capacity to involuntarily commit or take involuntary commitments into your care, we just really want to know, how are you going to assure that the culture shift to this voluntary person-centered care is going to be maintained separate and apart from any involuntary efforts. And I would encourage you to look at that from the client, the consumer's point of view too. How are they going to know? How are they going to know that when they call you and you're reaching out for services? How are they going to know that they're not getting the involuntary side of the house and they're really getting the voluntary side of the house? So to try and be as clear as possible on how you separate those two. The question about, can this be determined through policy and protocol? Absolutely. I would love to see those clear things be established in policy and protocol, and then how is that communicated to the team? Next question I have, and then I'll pause, Hashim, because I know you're keeping up as well, but please explain readiness expectations for the agency in regions where there are not currently providing services but would like to. It's a great question. We know that, as many of y'all know, we just finished up our regional meetings. We met with, had a regional meeting with every one of the 10 regions in the state. And yeah, absolutely, the readiness is all over. We have everything from parishes and regions that are certainly, they're already actively doing some of this. So in that extreme. And then we have others that they are, they're struggling to figure out how to get people that are in crisis into emergency departments. They haven't even really thought about this voluntary level of care, mobile crisis care. So there are extremes throughout, and then there's everything in between. So the readiness is basically, we're take that into consideration, right? So when we look at your region, and you'll notice in the RFA, we ask you to identify the regions that you're proposing to provide care for. We're going to take that into consideration. How ready is the organization or organizations that are applying for that level of care to provide it? And we haven't looked at any of the applications yet since they're not closed, but I would suspect that there may be very few even applying in certain regions. So a lot depends on who's applying and what they might look like. Again, I'll go back to those earlier pieces that I just highlighted. We definitely want to know the leadership. We want to know that local connection, collaboration capability. The agency's infrastructure or proposed infrastructure, and that it's realistic that they can pull it together when these services need to be launched. Hopefully that answers that question. The RFA states that the agency agrees to accept the rates in full. However, it does not give a time frame Is this for 1 year? I honestly don't know the answer to that question. My understanding is to start the stand-up of these services. Those rates are purposely posted as part of the RFA, because part of implementation, right, is you've got to understand the business and what you're getting into, including the delay in being able to stand up a team, some of the delays in standing up the team to then actually providing services, which will not be immediately at full capacity, and we'll be building up to that full capacity. So all of those factors are certainly part of the consideration for a agency from a business standpoint and scope. Whether those are and the time frame is just for a year, I do not know the answer to that question, and we'll certainly encourage send that question as well over to LDH as they are putting together their own FAQs. But we do know that initially the startup, the stand-up of this, the rates are what they are. We don't expect any changes in that. That is what's been clearly communicated, and I would expect that those are exactly what people have to work with no guarantees that they would change. What role title does the letter CRC reflect listed on the service requirements? CRC. Hashima, you know that off the top of your head?
I do not. Maybe.
Title to the letter CRC. Not sure where that is, but if we can do a quick search on it, maybe we can get
Looking for
context.
it. 1 second.
I'm going to keep going while you look for CRC. Billing.
Dr. Philby, Crisis Receiving Center.
Gotcha. Thank you. So the title does the letter CRC. It's Crisis Receiving Center, reflected in the service requirements. Crisis Receiving Center is the translation. Will billing of these services go through the MCOs or through a different avenue? If through the various MCOs, will their various crisis and crisis follow-up request protocols be the same? That is beyond the scope of the RFA training. It's a good question. The one thing I do know is the billing does go through the MCOs. This is a Medicaid managed care function, so the billing will go through the MCOs. We do intend, it is part of our training intention, that we will have a whole section for the training on billing and reporting that we'll build in, so everybody understands how to do that. That piece of our training curriculum is not finalized yet, but billing will go through the MCOs. I do know that much. Let's see. Does mobile response refer to individual mobile or team mobile response? Good question. The vision at this point is that mobile response will be in teams of 2 at least. And those teams of 2 could be bachelor's peer support, bachelor's professionals that go out under the clinical supervision of a licensed provider that's on call and available. But it would be in teams of 2. I have not seen anything in our discussion or in our training that would suggest that we would be sending out any individuals into the field without backup. The rates for crisis receiving chairs has a 1 hour and a per diem difference. Are there guidelines already created to when to utilize which code? Again, great question. We'll make sure that that gets posted over to LDH and the MCOs. I don't know the answer to that as it relates to the training. So, and just to clarify as well, crisis receiving centers, I just got a note, is also, it is a licensing type. So if you're asking exactly what that is, it's a licensing type under the Medicaid manuals. All right, a lot depends on where the referrals for mobile crisis come from. Is it known where the referrals are going to come from? So yes, so this it's a great question. So this is part of that, again, that readiness, who most ready. This is going to require two things. One is having a great working relationship with your local region, because people are going to have to understand what services are available and how to get to them. We are going to be depending a lot on partnering with our local teams to help that happen. Because we do believe that, you know, it's a local relationship. So just like any service that's being implemented, there's a degree of marketing, reach out, connecting, building a network, and that's certainly going to be expected here. Where the referrals are going to come from, people will have the capacity to call in. This will be in the soft launch. It's going to those calls will actually go into the managed care organizations, which already have that crisis care element for their service members, where they can call in and ask for help and try and be directed in the initial part of the launch at the very beginning. Those calls will go to the managed care folks. And then those organizations will be working to then move those calls over to the mobile crisis response teams or refer them to the walk-in centers, wherever that might best fit. Some of those calls may be resolved just via the call, but that's where the referrals would come from. We would expect also people have local partnerships, right? So that law enforcement that goes out to a call and says, you know what, this is not a law enforcement call. This could really benefit from mobile crisis. Their ability to reach out and make that connection with the calls. And again, it's going to be tricky. And that's why I keep on telling you, we're looking for folks that are very ready to be innovative with us. It's going to be tricky up front because all of this is going to be directed to members of the managed care plans, Medicaid managed care plans that are 21 and over. So it's a little bit tricky that for just an example, law enforcement would go out. They've got somebody 21 or over. They said, you know, this could really benefit from mobile crisis. Right now, there's going to have to be that connection and verification that they are in one of those plans. That is not the long-term hope, but it's going to take some coordinated effort and people that can stomach some of the back and forth as people get frustrated at the initiation of services, that it didn't go exactly as hoped. And how do we know what the expectations are? How do we know how to get to care? How do we know what not to try and get into this care? Those people that wouldn't qualify and not frustrate those efforts if they don't qualify for this initial launch of the Medicaid for 21 and over, that are people that are within the MCO's care networks. Still going down my list, keep the questions coming. The RFA states that there are distance and response time requirements for services within the regions, and this may lend itself to multiple locations, but does not list what those are. Has distance and response times been determined? So yes, so the presentations that have gone out from LDH on the crisis services and in the service definitions, I think you'll find urban centers, 1 hour response time, rural areas, 2 hour response time. And we're looking for people to be creative. We've learned a lot in this year plus and a half of COVID, remote work and everything else, that there's nothing magical about a sole office. So we're hoping that we have people that are out there and creative and can think about how to place team members strategically and recruit team members strategically so that they're available in different regions or different areas of a region to be able to meet those response times when called. Hashima put the service definitions back up in the chat. Thank you, Hashima. So certainly refer to those. Getting to the next one. The RFA states that by submitting, the agency agrees to accept the rates in full. Yes, to be very clear, yes. When we talk through this with LDH and managed care organizations, that is to actually, from you all applying to be trained and everything else, we need to give you something very anchored to know that this is what you're getting into. So yes, those rates are what are being asked to be accepted if you are applying to be trained in this and go and not to anticipate that there are any different rates available. Does this exclude our ability to bill professional codes 9,000s for crisis receiving center, chairs, service line, behavioral health community, crisis care service line, or is this determined by the MCOs? I don't know how to answer that question, so I will make sure we copy paste it and pass that on to LDH, and they'll work with the MCOs to figure out how to answer that. Submitted application, thinking it was due by the Zoom call today. Is it possible, can we submit another application? I'm getting clarity on questions that were asked in the application. Absolutely. So what I would suggest, if you are withdrawing an initial application, if you would just email that evidence to practice email that Hashima put in, just to save us to know that we will delete that application. We just need something from you that says, please delete application that was submitted on whatever day, and that you intend to resubmit, and that will just save us time. So please, yeah, absolutely. Hashima just dropped the email back in the chat, but please email us and just say, please withdraw the application from X agency, and we will resubmit, and that way we can take it down and go from there. Believe it or not, Hashima, unless you see something,
Yeah.
I think I've gotten through all the questions so far.
Great, you did a good job. I have one question that came in directly to me, and it was, is the peer support specialist employee a requirement?
Peer support specialist employee requirement. I don't want to give a formal answer to that because I'm not sure. I think my understanding is if you look at the service definitions, I think you have the ability. It is the ability to do both, but I don't want to both hiring clinical staff, bachelor's trained staff, or peers. The only thing I would say from my perspective on this, an essential part of the vision of this is more peer activity. It has been shown from those of y'all that have been on the other calls about the crisis system. We've said a couple of times about there is no true evidence-based program for crisis. However, there are definitely some best practice and some guidelines out there. And one of the best practices that we're seeing over and over again from states is that the people with lived experience, that peer experience adds a lot to crisis response. So I'm not saying it's required. I think there may be some flexibility in how you formulate those teams, but I certainly would say it is looked very favorably on if you can do it successfully and engage those peer responders as well at some level of the care of the crisis response.
No other questions came to me. I don't know if there are any to you.
Just got one. Hold on. The RFA states that there may be grant funding available. What's the process steps to access the grants? So there is not a specific funding available yet. There has been discussions about, and again, this just goes back to implementation science. We know that we are asking a lot, and just covering the training, the cost of training, have experts being there to help train is just one part of it. Having the ability to bring on board people, sustain them for a period of time while things are getting up and running is additional, certainly additional funds. There have not been a specific grant funding source available. We're certainly discussing it and open to continue to look for it, but as soon as, if there are any grants available, if there are funds available, we'll certainly announce that as well. And we have done that. Just it's not something that the state hasn't done. We've actively worked actually with some sustainability and just capacity building grants with EBP providers in the past. So it is not something that hasn't ever been done before. Right now, for this specific crisis service, we just don't know of any specific grant funding that's available to help with that yet. How many teams are recommended for each region? Great question. So sometimes it truly is a great question, because we worked on clarity of that language multiple different ways to try and be very clear what it is. This initial soft launch, there is going to be selected in terms of readiness to go. For each one of these services, so the mobile crisis, the community support, the mental health walk-in center, behavioral health care centers, the crisis stabilization beds, there's going to be one service provider selected for each one of those. In each region, there'll be a service provider identified for each one of those levels of care. Now, this is where it gets complicated, and that's why I said it's a great question. It could be one provider that provides all 4 levels of care. That's a possibility. It could be, the other extreme is it could be 4 providers offering that care. So it could be in a region, it could be between 1 covering everything, or 4 individual providers that are covering those individual phases, and then anything in between. We could have 2 that are splitting the difference of care. We could have 3. Somebody does, crisis stabilization beds. Another person does the behavioral health walk-in centers. Another agency does the mobile crisis and community support suites. So the answer is and just to be clear about this RFA for training, you have the ability to select the exact level of care. And when we presented at the beginning, that training element in January is when we start training the mobile crisis and the community-based supports. Very clear, near to that, after that, we'll start focusing on the behavioral health walk-in centers and the training for those groups. And then after that, we're getting into April, May of next year, we'll start training the crisis stabilization. So it's a rollout that is being systematically rolled out. It's not all at once. So if you are, just for example, you apply on this RFA to be a crisis stabilization bed center, we'll have those selections and everything out. But there will be, there'll be much more time between that training, standing up that workforce, staff, whatever you need to do to get the space ready and everything. There's a lot more time in that than there is for the mobile crisis and the community supports that we're going to be standing up first and much more rapidly. It's a great question.
Dr. Philby, there's a question that came in. that says, can I apply for multiple regions? Example, I currently provide mobile crisis in region X. Can I apply for Y and Z?
Yes. My shortest answer of the day, yes. So we absolutely are taking via the applications, and you'll see it right up front in the application process. What level of crisis response care are you applying for, and what regions? And you can check as many regions as you are interested in. The one caveat to it, you'll notice, is it is regional. So I want to be very clear about that. It is regional. So anybody that is applying needs to think about regional coverage and not just a single parish coverage. We know there's certainly parishes that are much more populated, and we'd want to hear certainly how you're going to cover that very populated parish, but you can't ignore the other parishes within that region. It needs to be, there needs to be consideration for the entire region. And that goes for multiple regions as well. All great questions. I love y'all's interest. I'm hoping y'all make it really hard on me and the team to really filter through all these applications. We're grateful for the MCOs and the advocacy organizations that are going to help us review as well. And I expect there are going to be some tough choices to make to get these initial teams up and running.
Dr. Philby, we have another question. Is there a fee for the training?
No. So let me say no and then put a caveat on it. Lesson learned, because I used to give that answer way too frank, just like I just did. We know that agencies have a cost even when we say, hey, we're offering free training. So the reality is there's no cost to the training itself, because we are being supported by LDH to bring in the experts, have the trainers trained, and we are contracting, funding that curriculum build, the trainers, the content experts that are helping with the training and the curriculum build. So the training itself will not have any price tag associated with it that you're going to have to pay for the training. However, the caveat being that we certainly understand from an agency perspective that none of this is free. That staff's time, the loss of revenue while somebody's sitting in training is to be considered. That staff's salary is still being paid while they're sitting in training, even when the training's free. So, I just put that honest caveat on it. Yes, the training, there's no cost that we are going to require to help people go through the training, but there could be certainly staff reimbursement costs in terms of their salary reimbursement, hourly reimbursement, the loss of revenue if they are an existing provider within your agency while they're sitting in a training room, that loss of revenue, the training that will be required that we are going to stand up for the in-person. We are currently looking at an in-person day of probably ranging from a day to a day and a half. So there'll be potentially some travel expenses that go with getting people to that training. We're going to try and bring that out regionally, so it's not far travel, and to try and spare some of those expenses, because it's a lot cheaper for us to send 1 or 2 people out versus trying to get multiple people all into a training in a specific location. So we're going to try and make that as close as possible in the regions. But that'll be at least a day, day and a half that you can expect that they will be in person and engaged in the training. The rest, like I said, will be a combination of live online. And we also are very knowledgeable now. Thank you, COVID, once again, that we're very knowledgeable about the mental break that has to happen. Anything beyond about a 2 to 3 hour training is about all you're going to get with attention, including mine. So we are going to do those live sessions where we spread them out to spare the trainees. That just FaceTime. We're not going to put somebody on a computer for 8 hours and having to have them engage a computer that long. It's not fair on them. And then the asynchronous stuff, the stuff that will be available to do on your own, we will post that. We have the center maintains a training portal, and we will have some things that are accessible at your own pace, at your own time, to be very flexible with the workforce, and you'll be able to complete those trainings, and we will have records of who completes those and how they do. There'll probably be pre-post testing, all that stuff you all know well from online trainings. But so we'll have a variety of ways to deliver the training, trying to be very respectful of, to go back to the cost question, that it does cost something no matter what to send people to training, even when the training is quote free.
Dr. Philippi, there are two questions that just came in. The first one is, will agencies or providers need to reapply each year to cover these services, or is this for a particular period of time?
That's a great question. In terms of training, I would suspect if we have areas of the state continue to have needs, we'll put out more RFAs regarding training to actually provide the service. That's a credentialing contracting question between the agency and the managed care organizations, and it depends on what those contracts look like between the provider and the managed care organization. From our perspective, as we see training needs develop, we'll probably put out RFAs similar to this to encourage more providers in areas where providers may have not worked out, or there's a gap in service, more need for providers. We do intend, and we understand that, workforce are what they are. We do absolutely, we're planning and suspecting that there will be workforce turnover. This is going to be hard work. We know that from crisis work in other states. Mobile crisis it's a high demand working environment. So we're going to try and prepare people for that. We're going to try and help them understand the best way to support themselves and each other in that kind of environment. But we're also being realistic that we're going to have turnover, and we need to be able to help agencies with that turnover. So we're going to have rolling trainings. We haven't specifically figured out exactly how to do that, but you can expect that we will have some level of rolling training that goes out anywhere from 3 or 4 times a year to at least 2 or 3 times a year, so that as staff turns over, we can get new staff in for the agencies and have them ready to go.
And we have 2 more questions. Would you consider providing the training twice so that agencies could have their entire staff attend the training? They can't send everyone at one time and continue to operate.
It's a great question. Would we consider it? Sure, absolutely would consider it. I know our initial training, we are set on a deadline to make sure that we meet what we've agreed to with Louisiana Department of Health in terms of having that initial training by no later than the middle of January, beginning of January, middle of January. But we could absolutely, once we stand this up and we get through that initial training, absolutely reasonable. I just like you all as agencies, I need to do some business planning around that to make sure we've got enough trainers and enough coverage, but I think it's an absolutely reasonable request, and I'd be happy to see how we could do that and do it close enough together where you've got people trained and ready to go and aren't waiting too long for that next training.
The other question is, will there be other opportunities to apply if not able to meet current application deadline?
The expectation is, I don't know that. That's going to be driven a lot by the gaps, needs, and services, what this looks like as it rolls out. But my anticipation, if we are similar to any other states that have gone before us, as this becomes known and it becomes solidified in the system, it's going to be a very needed service. It'll be a sought after service. There's open conversations about, can we even bring this to the adolescent population that is desperately in need of it as well. So there's certainly conversations about paying close attention to how this will continue to develop. So this is an initial launch. This is like I said earlier, soft launch. It's an initial launch. Get at least the initial teams up and running, and then really reassess what do we have, where are the gaps, where are the needs, and plan from there. So let's see, we've got about 3 more minutes. So Hashim, will you do me a favor? Will you throw back up there if you haven't already done it? Because I've been, oh, you've already got it up. Never mind. I see the slides already up. Just call people's attention to this. Hashima put in the chat our LA Evidence to Practice email. And if you think of other questions, we will try and as quickly as possible update that FAQ. That'll be posted on that page. And we look forward to your applications. We're excited. We're absolutely thrilled that the state asked us to partner on this. This is a wonderful opportunity to really shift behavioral health care in Louisiana. And I'm excited to have y'all's interest, and I'm equally excited to see the applications and get those first teams up in here, trained, and moving this forward. Hashima, do you see anything else before we close out?
Nope.
Excellent. Well, thank you all for your time. You know how to reach us, and please let us know. We look forward to your applications. Thank you so much.